less crowded today. Maybe you're right, because to the CMR Journal Club today I'm hosting from actually from Italy in Tuscany, and because inside was too loud and no internet in the place I'm staying currently, so I had to move out. I hope the acoustics are okay. It's a particular pleasure for me to introduce two papers on myocardial oxygenation or blood oxygenation in the heart. As probably many of you know, has been one of my areas of research, looking at changes of oxygenation in the myocardium using T2 star sensitive techniques. And today we have two fascinating papers on that. And we'll jump right into the first one, presented by Felix Tröger from the University Clinic of Radiology in Innsbruck, Austria. And the paper is titled "A Reduced Right-Left Ventricle Blood Pool T2 Ratio Predicts Congestive Heart Failure After ST Elevation MI." So Felix, take it from here.
Yeah, thank you very much for the invitation. Good afternoon. In Austria, it's already afternoon. Yeah, I'd like to present that paper. As you already said, it's about reduced right-left ventricular blood pool T2 ratio in congestive heart failure after STEMI. My name is Felix Droger. I'm from the Cardiac MRI Research Group in Innsbruck in Austria. And the current work was published in January in Clinical Research in Cardiology. So to get to the background of all that, basically, imaging data about congestive heart failure after STEMI are quite scarce. So there isn't much to talk about. Basically, the usual suspects are quite well known. So increasing age predisposes for congestive heart failure, female sex, diabetes, and of course, in terms of imaging parameters, larger infarcts are associated with congestive heart failure, microvascular obstruction, and intramyocardial hemorrhage. The reason why we did that work here was because I found a certain paper by a German work group who measured the T2 ratio in the blood pool of the left and the right ventricle in patients with chronic heart failure. And apparently a low ratio, which means the RV blood pool T2 divided by the left ventricular blood pool, a low ratio was associated with poor performance in the 6 minutes walking test. As congestive heart failure is quite common in patients with myocardial infarction, we thought, well, in our large ST elevation myocardial infarction cohort, we could take a closer look at that and investigate this T2 ratio, because it's quite a simple, quite a basic parameter in our cohort, and see whether it is associated to congestive heart failure as well. So our objectives were basically to measure this ratio. The second one, as I said, to assess its association with major adverse cardiac events, and especially congestive heart failure. And third, to evaluate whether there is any prognostic value in all of that. Basically, our study population consisted of patients with a first-time ST elevation myocardial infarction, and all of our patients were treated by primary PCI within 24 hours. So these are our inclusion criteria. Basically, that's all. Exclusion criteria, quite simple. All of our patients had to be at least 18 years old, had no chronic kidney disease, and had to have a Killip class of less than 3 at the time of CMR. And of course, no CMR contraindications. To sum all that up, our CMR protocol included a functional assessment. Of course, we measured the infarct mass, we measured MVO, whether it was there, and secondarily, how big it is, and to assess intramyocardial hemorrhage. For the T2 maps, I don't want to go too much into details how those were obtained, but basically, as I told you before, the T2 ratio was measured in the blood pool, excluding the papillary muscles, and basically it was computed as the T2 of the right ventricular blood flow divided by the T2 of the left ventricular blood flow. In the figure here, you can already see examples of these measurements. So in the left image here, you can see a patient where the left and the right ventricular T2 in the blood pool is equal, so it's 100%. And on the right-hand side, for example, you can see the other way around. So a patient with quite low values in the right ventricle and quite high values in the left ventricle, which results in a T2 ratio of 60%. So it's a very low ratio, and in here you have a very high ratio. All of our patients were re-examined 4 months and 12 months after the infarction clinically, and in most of our patients we also did telephonic follow-ups. So we phoned them and asked them for whether they had any major adverse cardiac events, especially congestive heart failure. And congestive heart failure in that sense was defined as the requirement of IV diuretics after discharge or any signs of heart failure necessitating hospital readmission. So these are quite standardized definitions. I'll talk about that later in the limitations section, but that was the way that we defined it in here. Statistical analysis, besides the usual descriptive statistics, we also did a net reclassification improvement and a binary logistic regression to find out the prognostic value of all that, and a Kaplan-Meier plot to see the CHF-free survival. Our study included 604 STEMI patients. So all of these patients had their first myocardial infarction. All of these patients had a primary PCI within 24 hours. And all of these patients had a CMR, cardiac MRI, within 4 days after their infarction. Congestive heart failure thereby occurred in 43 patients overall, so in 7%, within a median observational interval of 3 years. So via telephone calls and follow-ups, we had a median observational interval of 3 years. And of course, which is quite intuitive, as you can see in the table here, patients with congestive heart failure were, and that's in line with literature, they were older, they were more commonly affected by diabetes or hypertension. They had higher lab parameters all over, basically, except creatinine. And of course, they had a lower ejection fraction, lower global longitudinal strain, and so on. Larger infarcts, higher prevalence of microvascular obstruction. But in terms of our T2 ratio, you can see the following. The left ventricular blood pool T2 was not different between those groups. However, the right ventricular T2 values, they were significantly different. So they were higher in patients who did not suffer heart failure. And what is more, the relative value, so the T2 ratio, was significantly lower in patients suffering heart failure. And what is more, even more, we defined a threshold of 60%, which is the 10th percentile. And patients in that group with the heart failure were significantly more often below that threshold. So these are the important findings concerning this. There's again, so we dichotomized that at 60%, which is the 10th percentile. And if we take a look at it the other way around, we can see here the comparison between patients above and below that value, and it looks quite similar to that. So these patients with the lower values were significantly older. They had lab data all over, which indicating more severe infarctions. And they had, of course, larger infarctions, more often MVO. So it's quite similar to the CHF patients. If we take a closer look into that, we can see that a reduced T2 ratio below that threshold was more common in MACE patients. And of course, it was more common in these patients with congestive heart failure. And we did, as I said before, a net reclassification improvement analysis, which also showed that if we added this ratio with a threshold of 60%, so if the patient was below that threshold, to those traditional risk factors, we could have reached an NRI of more than 30%, statistically significant. So once again, you can see here the table describing all those MACE subpoints. So all-cause death was more common in patients with a lower T2 ratio MACE, as I said. And of course, last but not least, the congestive heart failure was much more common in those patients with a decreased T2 ratio. And here you can see the Kaplan-Meier plot. So the CHF-free survival was significantly shorter in patients with a lower T2 ratio, which also leads into the same direction. We also did a Uden indexed threshold, which was 67%. It did not make much of a difference. But concerning univariable and multivariable analysis, most importantly, multivariable analysis, you can see that a T2 ratio below 60% also was significant in those two models, which means that it can be seen as an independent risk factor for congestive heart failure after STEMI. So to sum up, the results of our study basically were, I was short of colors, but the T2 ratio is significantly decreased in those patients with congestive heart failure. A ratio below 60% was associated with older patients and patients with more severe infarctions. Patients with a T2 ratio below that threshold had MACE or suffered MACE more frequently and experienced heart failure earlier and more often. And patients below 60% T2 ratio, or the other way around, the T2 ratio of 60% or less was a predictor of congestive heart failure, independently of those other risk factors that I talked about. Just addressing a few main points of our discussion. So as I told you before, there is a work of a German work group about this ratio. In chronic heart failure patients, there are two other different papers about that. One of them is with the T2 ratio in patients with left to right shunt. It was the other way around, so it was an increased T2 ratio in those patients. And another study with the ratio in pulmonary hypertension patients which showed that the T2 ratio was also significantly lower in those patients with pulmonary hypertension. Yeah, one point why we used the ratio instead of absolute values was because the absolute T2 values typically are vendor dependent and are device dependent, so they differ from device to device. And the next thing would be, what is the pathophysiological background behind all that? Fairly and squarely, we don't really know, but lastly, we said that the blood pool T2 ratio is to a high likelihood associated with the oxygenation of the blood, which basically would be the most sensible explanation for all that. And yeah, basically we talked about this. We have showed all these traditional risk factors and that the T2 ratio below 60% adds some sort of prognostic value to all of those. I just want to go through the most important limitations. And I think the most important limitation in that case is that our patients had a Killip class of less than 3, which is a limitation in the sense that patients with a higher Killip class are more prone to heart failure. And the next point, as I already addressed before, is the definition that we used for heart failure, which of course can be a bit widened, but we used quite a standardized definition. And of course, all of our patients were first-time STEMI patients, which are less prone to heart failure compared to patients who already had their second or third myocardial infarction. So I'd like to conclude. I hope you have seen that the right ventricular, left ventricular blood pool T2 ratio, which it basically is an easily applicable CMR parameter that does not require any contrast agent. And we have showed that it is apparently linked to congestive heart failure after myocardial infarction. Especially a T2 ratio less than 60% yielded or provided prognostic information for CHF after myocardial infarction. And lastly, patients with ventricular T2 ratio below 60% experienced congestive heart failure earlier and more frequently. And yeah, last but not least, I'd like to show you our central figure, which also summarizes all this. And with that, I think I'm already through. I'd like to thank you for your attention. Are there any questions?
Hi. Excellent talk.
Thank you.
Yeah, Felix, I just wanted to know, your all studies showed EF of 49% average. Did you have any study where the low EF have been examined, all the ratios?
Sorry, you mean a low ejection fraction?
Yeah, because I saw most of the studies are average 42 to 55 EF. So
You mean
any
that
changes?
line here?
Correct. So did you get anybody less than those below 20 or something? How the response in those cases?
You mean whether we have stratified for ejection fraction?
Yeah.
No, basically we did not stratify for ejection fraction. I mean, one of the issues with that is that there are it's only a small cohort of patients below 60%. I don't think that would have made much sense. But basically, as you can see here, the ejection fraction was also lower, of course, in these patients, which would make sense concerning that it's linked to oxygenation.
Hi, Matej.
I'm sorry. I dropped out because the internet was not stable. Okay, but I think you already started the discussion. Fantastic. So go ahead.
Okay, I just wanted to know about EF, low EF patients. In India, we see a lot of patients with the very low EF, all infarcted, less than 20. It times difficult those studies and all. So I just wanted to understand.
Okay, yes. That sounds like a very, very low ejection fraction. I think we did not see any ejection fractions, or at least we did not see many ejection fraction patients below 20% or something like that. So I think for myocardial infarction, we're quite high with the ejection fraction.
Okay.
I don't know if you saw, there's a question that was put in the chat by Graham Wright. I don't know if you want to say it yourself or if you want to, I can read it out for you.
Sure. Interesting talk, interesting result. So I'm just trying to get down to the physiological aspect. So what do you think is the cause of this reduced T2 ratio in these patients? Presumably, it means the right ventricle has a lower oxygen saturation. But again, where's that coming from?
Yeah, basically that's the most important question. We are not able to answer that fully or to understand that fully yet. But for me personally, I think it's got also something to do with the function of the ventricle, because basically the way it moves the blood forward and how it blends in the oxygenated and the desoxygenated blood. But of course, that's very theoretical.
Correlate that with ejection fraction, because presumably lower EF should cause lower T2s in the right side.
Yeah, and it also correlates. Yeah, as you can see here. So patients with a lower T2 ratio also had a lower ejection fraction. Significantly.
Yeah, so that was also my question to discuss. To me, the most likely reason would be, but that would have to be then related to cardiac output. In patients with heart failure, you have often a lower cardiac output. So basically, the same oxygenated molecules have to stay longer in the system before they come back to the heart. So the oxygen extraction is increased, so they are more deoxygenated. So the venous blood is more deoxygenated. So have you related? I may have missed that. Have you related that to cardiac output? So not ejection fraction, which may not reflect cardiac output at all, but to cardiac output or even better cardiac index?
No, I don't think that we have done that.
Because
So
that
agree
would be worthwhile.
that, yeah, that's right. I agree that I also think that the T2 ratio is associated with the ejection fraction, but somehow it needs to be a bit more complex. And I don't think that we can really understand that.
Yeah.
But yeah, to be honest, we did not correlate it with cardiac output, neither with cardiac index.
Because we have done some preliminary studies, and although our data sample was not nearly as large as yours, there was a signal that the cardiac output was actually the strongest predictor for that. My other question was, of course, the ratio, signal intensity ratio, because in fact what you're measuring is signal intensity between right and left ventricular blood. That is highly dependent on the surface call intensity correction. So how did you make sure that the surface call intensity gradient across the field of view is harmonized between all these people?
Oh, that's a very, very specific question.
Yeah, because I mean, if you use the vendor provided surface call intensity correction, so basically the signal intensity is kind of evened out, because otherwise it will closer to the surface call it's always stronger. So the right ventricle is closer to the surface call, so the signal intensity would be much higher than for the left ventricle, except for a functional surface call intensity correction that is typically built in, but it depends on the quality of the surface call intensity correction, and also to some extent on the body composition, because if you have a lot of subcutaneous fat right off the bat, the right ventricle is not as close to the surface call, so the gradient of the signal intensity may be a little bit different. So, but you applied it everywhere, and the body mass index was similar between groups, so it's probably not a significant confound. I was just interested in that. Yeah, so we have actually more time because Peter Svoboda, actually there was a mix-up. He expected to present tomorrow, so we have more time, which is good, to discuss this here. Are there other questions? Because I actually have another one, but I don't want to hijack that.
I see there's a question in the chat. How would hydration and milk content, for example, iron-rich energy drink, affect the T2 ratio? Well, that's a good question. To be honest, I can't answer what sort of effect energy drinks would have on that. But we took a closer look on iron-rich, not iron-rich diet, but we tried to correlate the T2 ratio with iron levels in the blood, and surprisingly they did not very much correlate. So it was only Spearman's rho of less than 0.3, which is interesting. But of course we did not measure oxygenation, and we only correlated that with hemoglobin and serum iron. We did not really have a look at how the meal content, so the iron-rich diet or something like that, would affect it. But yeah, it could well be that iron-rich diet results in a higher iron levels, which would then again result in differences in those values. Right now, we did not see any difference concerning serum iron levels.
Okay.
Yeah.
Yeah, and then of course an obvious question from my side: have you also looked at myocardial signal intensity or myocardial T2 in comparison to that?
Yeah, that's a very good question. I think we did not look at it specifically in comparison to that. But on the other hand, I think for me that sounds a bit difficult, because in the acute phase after myocardial infarction, of course, myocardial edema and all that plays a role here. And I think that I think it's worth a try, but
no, for sure, Michael,
I think
edema will be probably the only really powerful impactor on the signal intensity. Yeah. So are there any other questions? I cannot from here see the chat. Danny, any other questions in the chat?
There was one from Wesley, but it's been addressed already.
Okay. Yeah. So then let's wrap it up. Thank you very much, Felix, for presenting that paper.
You're
To me, it
welcome.
was really impressive to see. And if you could show the Kaplan-Meier curve again, I mean, that was really quite impressive. That people with an abnormal or a highly abnormal ratio did so badly because it took less than a year to get them all. All those who are prone to heart failure, so 80% to that level. So it would be very interesting to figure out what differentiates those. And if you set the ratio below 60%, that's maybe something very important to pursue, and for others to look at. And of course, T2 star may be another opportunity here to look at the oxygenation, because it's less confounded by T2 effects from water, etc. So that may be interesting, and hope that others will pick up that pattern and look at that more closely. So the other study that we wanted to present today, we will have to postpone that. That was on development and validation of a non-invasive model of mixed venous oxygen saturation, also in heart failure. And that was actually about measuring oxygenation. So we will discuss this another time, but to me, that's a strong signal that oxygenation is something that we can address and CMR. So thank you very much for presenting that paper. Thanking everybody for joining, even though there was a Jewish holiday today, and I apologize for having missed that. We had close to 40 participants, and so I wish everybody a wonderful day, and all the best to you, Felix, and your team.
Thank you very much. Thank you.
Bye-bye.
Goodbye.
Thank you. Thank you very much. Goodbye from India.
Bye.
Wish you all the best.